Hello everyone, we are starting with Graves' disease, which is a part of thyrotoxicosis. We are quoting the Harrison 21st edition. Let's see the overview of the Graves' disease. First, we'll be discussing of thyrotoxicosis. Secondly, we're discussing the Graves' disease, its epidemiology, pathogenesis, clinical manifestations, lab evaluations, differential diagnosis, clinical course, treatment. So here, first we should discuss what is thyrotoxicosis. Thyrotoxicosis is a state of increased thyroid hormone in the body. So it just means whatever, if the body has more thyroid hormone production, or what in what sense it may be, increased thyroid hormone, that will be thyrotoxicosis. What is hyperthyroidism? Hyperthyroidism means increased thyroid gland function. So thyrotoxicosis is in the body, the total thyroid hormone increase. Hyperthyroidism means the thyroid gland is increased in function. So hyperthyroidism is a part of thyrotoxicosis. Thyrotoxicosis has many sub features, including hyperthyroidism. The most common cause of thyrotoxicosis is Graves' disease and multinodular goiter, toxic multinodular goiter, and toxic adenoma. So now we will now we'll study more about Graves' disease, its epidemiology. Let's think that it is 60 to 80% cases of thyrotoxicosis that will be Graves' disease. Okay, we told that thyrotoxicosis means increased thyroid hormone. Among the increased thyroid hormone in the body, it will be 60 to 80% will be Graves' disease. Okay, female to male ratio is 10 is to 1, and 20 to 50 years of age it will be happening mostly. So age. Next, this is the slide from the Harrison 21st edition. So we'll discuss that what is the causes of thyrotoxicosis. There are primary hyperthyroidism, there are secondary hyperthyroidism, and there are thyrotoxicosis without hyperthyroidism. Okay. First one, Graves' disease. It is the most common cause of primary hyperthyroidism. Here, the gland is hyperfunctioning. In primary hyperthyroidism, the gland is hyperfunctioning. Okay. So the Graves' disease. Next comes the toxic multinodular goiter, the toxic adenoma, functioning thyroid carcinoma metastasis, activating mutation of TSH receptors, activating mutation of GSA, that is McAlbert syndrome, stroma ovary, drugs like iodine excess, that is Joe based down phenomena, which means iodine induced hyperthyroidism. Iodine induced hyperthyroidism, that is Joe's based phenomena. Iodine induced hyperthyroidism. In Wolf Chakoff, it is iodine induced hypothyroidism. Okay, hypothyroidism. Next comes the secondary hyperthyroidism. Here, the gland is normal. Something is making the gland to produce excess thyroid hormone. That is pituitary adenomas, pituitary tumor, which produces excess TSH. Second, thyroid hormone resistance syndrome. Occasional patient may have features of thyrotoxicosis. Chronic gonadotropin secreting tumors and gestational thyrotoxicosis. What is that? TSH stimulate the XCG stimulate the TSH receptors. We should know that the beta ring, something alpha or beta subunit. The subunits are similar to HCG and thyroid hormone. So it stimulates the TSH to produce increased T3 and T4. So the TSH will be low. Next is the thyrotoxicosis without hyperthyroidism, which means subacute thyroiditis and silent thyroiditis, which means that the destruction of thyroid, releasing so much thyroid hormone into the body. That is, other causes of thyroid destruction is amiodarone, radiation, infarction of adenoma, injection of excess thyroid hormone, thyrotoxicosis faciea, or thyroid tissue. These are the major reasons regarding the causes of thyrotoxicosis. Next comes the Ethiopathogenesis. The genetically factor HLA-DR, CTLA4, PTPN-D2, thyroid receptor gene. The concordance with the monozygotic is 20 to 30%, dizygotic is less than 5%. The environmental factors include stress, smoking, increased iodine intake, postpartum, HIV after heart, that is antiretroviral therapy, that is immune reconstitution. Next, autoantibodies. The major autoantibodies are thyroid stimulating immunoglobulin, which can be secreted from the thyroid gland, bone marrow, and liver. Next is, we also sometimes have anti-thyroid peroxidase antibody and anti-thyroid globulin, which can easily be they can be found by thyroid binding immunoglobulin assay. Okay, thyroid binding immunoglobulin assay. Through this, we can find these antibodies. Then cytokines, the extraocular manifestations or extraocular muscles infiltrations by the T cells. Interferon gamma, tumor necrosis factor, I interleukin 1, then fibroblast activation. What will happen? The increased synthesis of glycosaminoglycan in the intraorbital area will trap water, and the muscles leads swelling, which leads to intraorbital pressure, which leads to irreversible fibrosis of the muscle, which can sometimes lead to, mostly leads to proptosis. Proptosis, and in high major cases, it can lead to, that is, optic nerve damage. Okay, keep in mind. Next, the clinical features of this thyrotoxicosis is, or Graves' disease is, it depends on the severity, duration, age, individual response to excess thyroid hormone. Apathetic thyroid means commonly seen in elderly population. Features of thyrotoxicosis which are very subtle thyrotoxicosis features, or it may be masked. The patient will be having only some weight loss and fatigue. Okay, the features will be masked or subtle. Next, Next, we should understand the signs and symptoms of thyrotoxicosis in descending order of frequency. Okay, the symptoms: hyperactivity, irritability, dysphoria, heat intolerance, sweating, palpitation, fatigue and weakness, weight loss with increased appetite, diarrhea, polyuria, oligomenorrhea, and loss of libido. Okay, so oligomenorrhea, sometimes it can be amenorrhea in some cases. It can also be amenorrhea. Next, the cardiac features is tachycardia and AF in elderly patients. You see that it can also cause SVT. Due to this cardiac problem, there can be high output cardiac failure with can be bounding pulse. Such things can occur, bounding pulses. Okay, so there will be tremor, which is on outstretched finger. Then goiter, uh, some warm and moist skin. There may be palmar erythema, onycholysis, pruritus, urticaria, or it can be hyperpigmentations. Then muscle weakness, lid lag, gynecomastia. On hair, there will be diffuse alopecia in 40% of cases. See, this lid retraction is not at all a specific sign. Okay, the specific to Graves' disease is this one. 2 to 3 times enlarged glands, along with the these Graves' ophthalmopathy, Graves' dermopathy, Graves' acropathy. Okay, so we told that these are the specific features of Graves' disease. So thyroid ophthalmopathy means thyroid associated ophthalmopathy. In 75% of cases, onset will be 1 year before or after the onset of Graves' disease. Remaining patients, there will be the onset will be after later years after the thyroid problems have occurred. At that time, the problems may be normal. That is why it's euthyroid ophthalmopathy, which means at the time of ophthalmopathy, the thyroid status will be normal. In 10%, it will be unilateral. And earlier symptom is grittiness sensations, eye discomfort, excess tearing. Severe cases will be corneal damage, periorbital edema, scleral injections, chemosis, diplopia. Most serious manifestations is optic nerve compression. It can lead to papilledema also, and peripheral field of vision defect. Then it can be permanent vision loss. Okay, this can occur. Next comes this dermopathy. Dermopathy means about the skin changes. It occurs in less than 5% of patients. Always occur in presence of moderate to severe ophthalmopathy. Most frequent location is the anterior lateral skin of lower leg, of lower leg. That is why it is called pretibial myxedema. Okay, it's non-inflamed. So next comes the acropathy. In less than 1% of cases, there will be clubbing strongly associated with dermopathy. Let's see the picture. This is one of the picture that I have seen in my OPD, that the patient is having lid retraction. It is chronic proptosis and exophthalmosis. This is actually exophthalmosis. Okay, exophthalmosis. Okay. Next is this is the case of proptosis with scleral injection. Proptosis with scleral injection. Periorbital edemas are also seen. Okay. This is a case. This is another dermopathy seen in the pretibial area. This is the pretibial myxedema. Next comes, this is the clubbing. Clubbing means it occurs. It's a dermopathy. It's not. It's acropathy also. Clubbing, acropathy. Next, why we should evaluating the lab evaluation of the hyperthyroidism or thyrotoxicosis THS level. So let's start with the lab evaluation. In lab evaluation, the TSH level will be suppressed and the total and free T3 and T4 will be increased. Okay. So there are also what is T3 toxicosis? In T3 toxicosis means there will be 2 to 5%. The T3 will only be increased. The T4 is normal. In T4 toxicosis, the T4 increased and the T3 is normal. Okay. The associated abnormality is elevated bilirubin, liver enzymes, ferritin, microcytic anemia, thrombocytopenia. Okay. Now we'll come to detailed evaluation of the thyrotoxicosis. On detailed evaluation, we first measure. What we first measure is measure TSH and free T4. TSH and free T4. If the TSH is low, and the free T4 is high. Okay, what does it mean? It means that it is a primary thyrotoxicosis. The problem is within the thyroid gland. Okay, so if the problem is within the thyroid gland, first we check for any features of Graves' disease. Do have any features of Graves' disease? So what are features we are looking for? We look for these features. Is there a diffuse goiter, thyroid peroxidase or thyroid receptor antibodies? Is there in ophthalmopathy? Is there in dermopathy? We check that. If there are these symptoms or these signs are present, then we can confirm it as a Graves' disease. Okay. If these symptoms are not present, what are symptoms? We just discussed a diffuse goiter, thyroid peroxidase antibody, ophthalmopathy, dermopathy. If they are not present, we can just diagnose it as a multinodular MNG or a toxic adenoma. How can you diagnose whether it is a MNG or a toxic adenoma? If you do a radionucleotide scan, okay, if there is an increased uptake, it is thyroid nodular, toxic nodular hyperthyroidism. If no or low radioiodine uptake, which means that the gland is destructive, there is destructive thyroiditis or iodine excess or excess thyroid gloma, like factitious thyroid factitia. Okay, thyroid factitia, like that. Then if no, not decreased, the rule out other causes including stimulation by chronic gonadotropin, because HCG has the beta group or alpha group, it has some action of TSH. Next, we look for the TSH and the T4. If the TSH is low and the T4 is normal, you measure the free T3 or unbound T3. If the T3 is normal, means both the T4 and T3 are normal. So we can conclude a subclinical hypothyroidism. Just follow up after 6 to 12 weeks. If you find that the T3 is high, is along with it is called T3 toxicosis, you just check for other features of Graves' disease. Next, you come the TSH is normal or increased with high unbound T4. The T4 is high and TSH is normal. What does it mean? It means that there is a TSH secreting pituitary adenoma or thyroid hormone resistance syndrome. Okay. In TSH secreting pituitary adenoma, the TSH will be increased. The thyroid hormone resistance syndrome. In thyroid hormone resistance syndrome, the TSH will be maybe normal with high unbound T4. Next comes another last one, TSH and unbound T4 normal, there is no further test required. This is a detailed evaluation of thyrotoxicosis. So the clinical course of the disease we will discuss in a short course. The clinical feature will worsen without treatment. Okay, with the mortality rate is about 10 to 30% if the treatment is not properly given. 15% of the patient develop hypothyroidism. How? 10 to years later. So we told that why the patient develop hypothyroidism 10 to 15 years. It is probably because of the destructive nature of this disease after long years, destruction. Okay. Then the ophthalmopathy, it worsen over initial 3 to 6 months. It worsen over the initial 3 to 6 months. Then there is a plateau phase for 12 to 8 months where there is no much destruction. Then there is it improves spontaneously. The radioiodine treatment, it worsen ophthalmopathy. Okay. The dermopathy appears after 1 to 2 years, may improve spontaneously. Next comes the treatment. This is a definitive approach that we should study highly. The treatment approach, first our aim is to rapid amelioration of the symptom, decreasing the symptom. Next is decreasing the thyroid hormone synthesis. For symptoms control, we can use beta blockers. Okay, we can use beta blockers like propranolol 20 to 40 milligrams 6 hourly, or alternately we use atenolol. Atenolol we use 25 to 50 milligram OD. Okay, so the relief from sympathetic overactivity like anxiety, palpitation, increased bowel activity, lid retraction, tremor, all those things can help with the beta blockers. Decrease thyroid hormone synthesis, we use antithyroid drugs. We use antithyroid drugs like thionamides. Then radioiodine and surgery, these are definitive treatments. So first we'll discuss about the antithyroid drugs like thionamides. It is used for 1 to 2 years prior to definite therapy. So we will think, what is a definite therapy? The definite therapy is either surgery or maybe either radio ablation. Okay, these are the definite therapy. So before 1 to 2 years before this definite therapy, we use the thionamides. The indications for using these thionamides are pregnancy, children and adolescent, severe Graves' disease with eye changes. The mechanism of action is thyroid peroxidase enzyme inhibition, iodination, prevention, and organifications. Okay. So now we'll discuss individual drugs. First, we'll discuss about the methimazole. In methimazole, we give dose according to the we give dose according to the limit, the upper limit. The ULN means the upper limit of the free T3. Okay. In first case, if it is 1 to 1.5 times the upper limit, we can give 5 to 10 milligram. We give 5 to 10 milligram OD dose, the methimazole. If it is 1.5 to 2 times the upper limit, the TSA, the free T3, we give around 10 to 20 milligram OD. Okay. If it is 2 to 3 times the upper limit, we give around 20 to 40 milligram OD. Okay. OD. And later, if the symptoms recover or there will be improvement, we taper the dose and we will go to a maintenance dose of 5 to 10 milligram OD. Okay. So next comes the drug is the carbimazole. We mostly use these carbimazole drugs because it has a immunosuppressive effect. The dose is 20 to 60 milligram with a maintenance dose of 5 to 50 milligram. The total duration of treatment is 18 to 24 months. That is why most patients, uncooperative patients, these drugs are not very useful because it's a long treatment and sometimes higher relapse can occur in using these drugs. And also, only advantage is that we don't need to do the surgery. The scar is not there. That's why. The adverse effect of this carbimazole is there will be urticaria, rashes, arthralgia. This carbimazole, this urticaria, rashes, arthralgia. The most important is this granulocytosis. Very important. It's an important question. Granulocytosis is very important. Okay, granulocytosis and aplasia cutis in neonates. The Propia uracil is mostly used in first trimester of pregnancy because it don't close the placenta. It inhibits additional activities. They inhibit the peripheral conversion of T4 to T3, and the dose is 100 milligram with a maintenance dose of 50 milligram TDS. So next therapy is a radioiodine ablation. These are these definitive therapy, radioiodine ablations and these surgery. Okay, so let's see that the iodine ablation is a definitive therapy in non-pregnant patients. Okay, strictly avoid in smokers and those with a moderate severe ophthalmopathy, like a moderate to severe ophthalmopathy can worsen. Indications if the patient is more than 40 years and a young individual with who are sterilized and the patient who is having short lifespan to some other disease. What we do is we allow a capsule injection, that is one iodine 131 capsule. It emits gamma radiation that are causing ablation of thyroid gland within 6 to 18 weeks. The dose is 185 to 555 megabecquerel. The complication is hypothyroidism, infertility, and secondary cancer can sometimes occur. Next, we see the definitive surgical therapy. The surgery is a subtotal thyroidectomy. What the indication is in case of severe hypothyroidism in children. And in pregnant women, he cannot tolerate thioamides because in methimazole, carbimazole is contraindicated. Probably propylthiouracil can be used in first trimester, and that also some cannot be tolerating that. In such case, we cannot use that. Then large goiter with severe ophthalmopathy or pressure symptoms. Next, the patient who requires quick normalization of thyroid function, we use such things. We quick normalization of thyroid functions. How will you prepare? The preparation of the thyroid gland is very important for the EC surgery. Otherwise, there can cause thyroid storm. That is very dangerous condition. Okay, thyroid storm. We use potassium iodide, methimazole, propranolol. These are drugs we use. This potassium iodide we use 5 to 7 drops only. Okay, we use only 5 to 7 drops, and each drop contain 8 milligram. Okay, so 5 to 7 means 40 milligram. We use 5 to 7 drop TDS for 2 weeks. So the complication can be hypothyroidism, hypoparathyroidism, hypocalcemia, and recurrent laryngeal nerve injury damage. The adjunctive therapies or radio contrast agents like sodium iodate, hypnoic acid can be used. Iodine elixirs like 10 drops of saturated solution of potassium iodide. Steroids like glucocorticoids. Cholestyramines 4 gram 4 times a day. What is cholestyramine? Bile acid sequestration. Why it is used? It is used. It can action is it reduces T3 and T4. Also, it increases the absorption of methimazole. It can be used only along with methimazole. Next is a potassium perchloride, lithium, calcium for skeleton health 1 gram per day. Okay. Next, the treatment of Graves' ophthalmopathy. We know that the mechanism of Graves' ophthalmopathy, the IGF interleukin 6, the fibroblast proliferations, all those things. First, you reverse the hypothyroidism. You stop the smoking. Okay, you can use some lubricants, tears, and eye shades. I use drugs like selenium, which is an antioxidant. We use steroids like glucocorticoid, which are anti-inflammatory. Then teprotumumab, which is an IGF-1 receptor inhibitor. We already studied this is the pathogenesis of causing that ophthalmopathy. Next, MMF, mycophenolate mofetil. Then tocilizumab, this is IL-6 anti-IL-6. IL-6 is also important. And this rituximab is anti-CD20 inhibitor. So the surgery is orbital decompression, fat decompression, bilateral tarsorrhaphy, recession of the Mullerian muscles. Next, the dermopathy, it is usually asymptomatic. As we all told, it is less than 1% only. So usually asymptomatic treatment is only required. Treatment is only required if there is any symptomatic cases, like if there is pruritus, there is local discomfort, the progression of lesion. In such cases, we do the treatment. The non-pharmacological treatment you use, avoid the tobacco, reduce the weight, normalize the thyroid function. In pharmacologically, what you do, we apply topical fluocinolone acetate, and we topically apply fluocinolone acetate. It's just steroid, then intralesional triamcinolone acetate, then pentoxifene, which is a drug. So these are topics. Thank you. Have a nice day. Thanks for listening. Thank you. Thank you.